Hi, my name is Amanda McHale, and I am going to talk to you today about self-directed injury and other directed violence. So for starters, looking over the epidemiology, we all know that suicide is a public health crisis. Approximately 1 million people worldwide die each year by suicide. In 2016, suicide was the 10th leading cause of death in the United States. Among those ages 10 to 34, it was the second leading cause of death. Ages 35 to 54, it was the fourth leading cause of death. There's twice as many suicides in the US as there were homicides. Suicide rate increased by 28%, 28% since 1999 through 2016. And the suicide rate is 4 times higher among men than women. For women, the suicide rate is highest among ages 45 to 54, and men, the rate is highest for ages 65 and older. And the rate was highest among American Indian, Alaska Native groups, followed by white, non-Hispanic groups. Firearms was the most common method used in half of all suicide deaths in 2016. Men are most likely to use firearms. Females tend to prefer poisoning, and they also use firearms. Some stats showed that suffocation was the second most common method used. In 2016, 9.8 million adults reported having serious thoughts about killing themselves, and about 1.3 million of those people attempted suicide. Among those who attempted, about 1 million had reported a plan to suicide to somebody. In more than half of all deaths, those who had suicided had no known mental health condition prior to ending their life. There's a statistic here from 2015 that SIB and suicide had cost the United States $69 billion. And in 2015, over 500,000 people visited a hospital for injuries due to self-harm. So it's a pretty significant problem, as you can see from the stats I have posted here. So to start out here, I'm going to go over some definitions. We need to keep in mind that the suicidal behavior can include non-fatal and fatal acts with or without the intention to die. Non-suicidal self-injurious behavior, or NSSIB, often serves as a relief for distressing emotions without the intention to die and involves inflicting deliberate bodily harm to self. The main feature involves repeated painful injuries that are commonly inflicted to resolve interpersonal difficulties or reduce negative emotion. Individuals are at higher risk for suicide attempts if there is a history of NSSIB. Average age of onset is 13 to 14, and late onset on average is 18 to 19. Behaviors include cutting, burning, scraping, and self-battery, which is hitting or head banging, like hitting yourself or head banging. Self-injurious behavior is direct and deliberate self-harming behaviors. Suicide attempt is considered to be an unsuccessful self-injurious behavior with the intention to die. An attempt may not result in injury. Suicidal intent, the person desires to die and has subjective self-destructive expectations. Suicidal threat can be nonverbal or verbal actions that are communicated with a planned suicidal act, communicate a planned suicidal act. Parasuicidal behavior is the intentional self-harm that is not lethal. Suicide is self-directed injurious behavior with the intention to die. And lastly, suicidal ideation includes thinking, contemplating, or planning suicide. It can vary in seriousness and is dependent on the degree of intention and specificity of plans. So lethality of suicidal behavior. Suicidal behavior is typically seen among people with depression, schizophrenia, borderline personality disorder, and substance dependence. Habitual use of self-injury doubles mortality rate and can lead to accidental death. There's currently no specific treatment or intervention program available. We need to keep in mind that past suicide attempt is the strongest clinical indicator of eventual death by suicide. So if they've attempted in the past, that's pretty high risk. So assessment is key. It's important to distinguish non-suicidal self-injurious behavior from suicidal self-injurious behavior, and suicidal behaviors, as well as understand the functions and risk factors. Practitioners need to understand the intention behind the suicidal act and behaviors, its function for the individual, as well as epidemiological aspects. Accurate assessment is more than just completing a required form, which we all know, and it's crucial to understand and review complex variables associated with the SIB. So differentiation of non-suicidal self-injurious behavior versus suicidal self-injurious behavior. I have listed here that people who engage in suicidal self-injurious behavior tend to feel that life is repulsive. They feel that ending life is a solution to any difficulties that they're experiencing, that may be associated with their mood, anger, anxiety, fear. They just want to terminate consciousness, and they have the intention to die. And their suicidal ideation is heightened. Level of physical damage and possible lethality is heightened to accomplish suicide and succeed in death. Serious physical damage can occur with lethal means of self-harm. And these people tend to have chronic, repetitive patterns of self-injury, with some have repeated overdoses. Gender is female. They've had more attempts. Males, of course, are more successful. There is less chronic repetition of SIB, I'm sorry. And their level of psychological pain is persistent and unendurable. They have had increased suicide attempts and methods and pain associated with pain analgesia during self-injury. Their constriction of their cognition, they have extreme tunnel vision. Suicide is the only way out, and they want a final solution. Treatment, as far as a decrease in discomfort following the act, there is no immediate decrease, and treatment's required. Risk factors for these people, of course, as I mentioned already, prior suicidal self-injurious behavior, SIB, and attempts, pain analgesia, and family dysfunction, and females tend to attempt more than male. And the non-suicidal self-injurious people, patients, their attitude toward life and death is life is less repulsive. They have more motivation to live, with more emotional dysregulation and dysfunctional coping. They've had more negative life events, and they don't have death-oriented thoughts as much. Ideation is heightened to low. Level of physical damage and possible lethality. They tend to use non-lethal means of self-harm with little physical damage. They have stronger identification with cutting and greater identification with death and suicide than, they have a strong risk factor for SIB. They often cut and self-hit. There's a higher incidence in females, higher frequency pattern of self-injurious acts. The level of psychological pain that they have tends to be intermittent and uncomfortable. Association with pain analgesia during self-injury, there's use of fewer non-suicidal self-injurious methods, a lower number of episodes. They have little to no constriction of cognition. They seek temporary solution. They know that they have choices available to them. They have as far as a decrease in discomfort following the act of self-injury, there's rapid improvement and return to their usual mood and cognition. It's sort of reinforced by a calming effect. Risk factors. Borderline personality disorder is most common risk factor, along with childhood abuse, genetic predisposition. Gender, there's really no conclusive data on gender differences. Some suggest more common in women. So assessment is key. Our book mentions the CASE approach, which stands for Chronological Assessment of Suicide Events. It's really important that we obtain fixed information on demographics and history, assess their level of suicidal ideation, their intention, plans, and motivation. And then the acronym is the PATH-WARM. This is a helpful acronym for us to keep in mind and to differentiate SSIB or the non-suicidal SIB. I stands for ideations, review substance abuse, whether they have a sense of purpose in life, their degree of anxiety, do they feel trapped, are they hopeless, have they withdrawn socially, are they angry, what is their degree of recklessness, and any mood changes. So step one of the assessment is we're going to explore present events. How close did they get to committing suicide or completing suicide? How do they feel about being alive? You want to get as much information as you can about the attempt. Why didn't it work? What method did they use? What planning was involved? What was the level of stress or hopelessness? Were drugs and alcohol used? Were there any interpersonal variables? You really want to help them tell their story without fear or shame. Use a gentle approach to obtain specifics. Try to normalize their feelings. For the patient who has a hard time admitting or denies that they attempted due to anxiety, fear of the outcome, fear of hospitalization or commitment or embarrassment. And of course, as always, with all our patients, you want to be supportive, non-judgmental, and culturally sensitive. Number 2, you want to make sure to get a complete overview of any history of attempts. This will help increase understanding of the risk versus non-suicidal self-injurious behavior, and to, of course, determine the lethality, frequency, intensity, and duration. Step 3, complete a recent history assessment. Excuse me. Spend time looking at the most serious past suicidal attempts or gestures to determine triage decisions. Patients may engage in what's called denial of the specific or downplay or distort their negative behaviors. So you want to watch for that and try to get as much info out of them as you can. Really build up that rapport. Symptom amplification. You really want to ask direct questions. For example, how many attempts have you made since you first felt down? Or have you thought about using such and such method for suicide, like hanging or overdose, if the person is in complete denial? Step 4, current suicidal ideation to determine safety needs. You want to emphasize the need to obtain reports from family, friends, significant others, and records to evaluate info and level of interpersonal support. So there's a variety of risk factors that contribute to suicidal risk or self-injurious behaviors. Demographics include male, divorced, widowed, single. The risk increases with age, and Caucasian. Psychosocial factors is unemployment, lack of social support, drop in socioeconomic status, a recent loss, access to firearms. Psychiatric, of course, is if they have any comorbidities or a psychiatric diagnosis or multiple diagnoses. Physical illness, do they have lupus, chronic illnesses with pain syndromes, functional impairment, nervous system disease, HIV, AIDS, or cancer. Psychological factors include anxiety, psychic pain, psychological turmoil, low self-esteem, fragile narcissism, perfectionism, and hopelessness. Behavioral dimensions include aggression, severe anxiety, panic attacks, impulsivity, intoxication, global insomnia, and past suicide attempts. Cognitive dimensions include, the polarized thinking, thought constriction, any childhood trauma, neglect, parental loss, physical sexual abuse, and genetic or familial factors of mental illness, abuse, family history of suicide. Protective factors include a stable support system, availability and ability to use adaptive coping skills, active participation in treatment, a sense of hopefulness, spiritual inclination, pregnancy or having children under age 18 in the home. Lethality risk reviews specifically the methods of self-injury that would be categorized as highly lethal, would be direct, like suicide attempt repeaters, single episode, suicide via overdose, hanging, use of a gun, or jumping from height. Indirect would be single episode, situational risk-taking, or high-risk stunts. Medium lethality would be atypical or major self-injury with multiple episodes, possibly. Indirect would be sexual risk-taking. Our book stated late phase anorexia, acute drunkenness. In lower lethality, the more common direct methods are common self-injury of the arm, wrist, leg cutting, burning, excoriation, or self-hitting. Indirect would be chronic substance abuse, misuse, abuse of prescribed medications, obesity, use of laxatives, and bulimia. So interventions, there's really no evidence for a suicide contract. It's not really recommended for patients who are newly admitted to the hospital, psychotic, agitated, impulsive, or in emergency settings. What is recommended would be to have the patient formulate a crisis plan for self-harm prevention, where they identify triggers for self-harm and include various coping strategies to deal with that. During assessment, it's important to build that rapport, to enhance engagement, address any resistance and anger, explore various defense mechanisms, that active listening and validation, therapeutic communication, and allowing them to ventilate their feelings is very important. So the goal of treatment for clinicians, we want to guide the individual with self-injurious behaviors toward gaining control over their behavior. You want to provide security while also exploring insight into their behavior. You want to make sense of self-injurious behavior thoughts and reset goals. Establish a hopeful future, and for sure address psychiatric illnesses, any current stressors, and limit, of course, make sure they have no access to firearms or means of suicide or self-injury. Evidence-based planning, ensure safety and security first. On the inpatient unit, we're going to make sure we increase their observation status if they're actively suicidal, or even, have thoughts of suicide or self-injury. And therapy and medications is also going to be important as well. You want to work with them so they can gain insight into self-skills and how they can self-manage, develop individual goals vested in hope, educate them and their family on symptom management and relapse prevention. And it's an interdisciplinary assessment and collaborative means to determine a reduction of suicide risk for the patient or elimination of the risk completely. You're going to want to make sure there's follow-up care of ongoing suicide risk assessment, and ensure that they're safe in the community when they're ready for discharge from the hospital, or in general if they're outpatient as well, of course. Various treatments involve, one is cognitive behavioral therapy. This focuses on cognitive errors, stressors, and behavioral responses that contribute to suicidal behaviors. We're going to want to address emotional, cognitive, behavioral, and interpersonal problems associated with the non-suicidal or suicidal SIB. DBT is also very powerful therapy, which combines CBT techniques with Zen elements, promotes a non-judgmental attitude towards one's own thoughts and emotions, and this can lead to the prevention of negative mood behaviors that lead to the non-suicidal or suicidal SIB. It helps focus on emotional regulation, interpersonal efficiency, distress tolerance, mindfulness, and self-management skills. It reduces the frequency and severity of suicidal behaviors by half. It also is known to increase adherence with treatment plans and social functioning, and there's been shown to result in a decrease in emergency visits and inpatient care for suicidal ideation. Motivational interviewing is also helpful. It focuses on the patient endorsing self-sufficiency. It helps establish a therapeutic union and discover ambivalence about suicide. It really puts the choice in the person's hands. The person's able to recognize their own ability to make good decisions and deal with negative feelings. It's been shown to improve confidence in making life-affirming changes, and it's shown to have decreased rates of involuntary commitment, inpatient psych hospitalization, and use of emergency services as well. Then there's the mindfulness-based cognitive therapy, which is also purposeful, non-judgmental, and present moment awareness. Allows the person to acknowledge their thoughts versus suppress them. And it decreases that thought suppression and depression associated with self-injury or suicidal ideation. There's a variety of pharmacological approaches for treatment for both non-suicidal SIB and suicidal SIB. The overall goal is to reduce that impulsivity, aggression, and mood dysregulation that drives that suicidal behavior. Of course, medications include the SSRIs, SNRIs, NDRI, and alpha-2 antagonists, mood stabilizers and antipsychotics, and the opioid antagonist. There is a biological theory of suicidal SIB. There's some theory that there's dopaminergic hyperactivity among those who self-injure. Also, there's the endogenous opioids that initiate and maintain that non-suicidal self-injurious behavior. There's chronic elevation of the endogenous opioids that lead to insensitivity to pain and sensory depression. And of course, these patients who self-injure don't exhibit the typical signs of pain after engaging in the cutting or injurious behavior. And some even report pleasure or euphoria that keeps reinforcing the self-injurious behavior. So the role of SSRIs in non-suicidal self-injurious behavior would be if the patient's reporting feeling really activated and anxious, they tend to benefit from an SSRI that is more sedating, like Lexapro or Celexa. If they have symptoms of lethargy, lack of motivation, the more stimulating SSRIs may be helpful, such as Prozac. In borderline personality disorder, our book noted that antipsychotics have limited effectiveness on the impulsivity and aggressive components. Antidepressants were not helpful at all for the impulsivity associated with borderline personality disorder, and anticonvulsants had the best results for the impulsive behavioral dysregulation. Best medications for that impulsivity in BPD are Topamax, Lamictal, Depakote, and then they also noted some efficacy with Abilify and Zyprexa for the antipsychotics. In children or adolescents, Geodon showed to have lower rates of non-suicidal self-injurious behavior. Naltrexone reduced the rate and frequency of NSSIB in adults, but not necessarily in children. And of course, other things we'll want to consider with medications, of course, is the patient preference, what has worked for them in the past, costs and drug interactions if they're on other medications that will be contraindicated with the medication you're considering. Children, just a couple points here in regards to suicide. There is some information in our book about increased suicide-related events occurring among children and adolescents who initiated medication treatment, particularly among adolescents taking antidepressants early on in treatment. However, the general conclusion is that most kids and adolescents do well on SSRIs. They thought the increase in suicide-related events occurred due to the SI was increased, or there was a new onset of SI. Could have possibly been due to increased agitation, irritability, less inhibited, or they had a mixed state with like a pre-existing bipolar condition. Treatment of depression may not reduce suicidality and should be aimed at targeting the suicidality, so that's something to keep in mind as well with kids. Assessment should include attention to both the intention, frequency, and intensity of the SI, or suicidal ideation, and behaviors. And treatment focuses on safety planning with patient and family, means restriction, which means making sure they don't have any access to means to hurt themselves, and recommend hospitalization when required. And then lastly, the autoerotic asphyxiation is life-threatening paraphilia that can sometimes be mistaken for a suicide attempt and can result in accidental death due to loss of control and consciousness. It's patients or people seek that hypoxic euphoria that results in the asphyxiation and leads to sexual gratification. These people tend to have no evidence of a psychiatric illness, no history of SI or current SI, no really recent stressors, no prior attempts of suicide. There's evidence of solo sexual activity, other paraphilias, and they also tend to have a self-rescue mechanism in place. Other signs of people who engage in this sort of self-injurious behaviors, you'll see impressions on their neck. Sometimes they keep short ropes under the bed or neckties with odd knots, and sometimes they'll have the subconjunctival hemorrhages. So that concludes part 1, and I will post part 2 here shortly, talking about other directed violence. Thank you.